All right, back for another exciting episode. Chapter 34, Head and Spine Trauma. So starting off with the introduction, we know that the CNS, or the central nervous system, it consists of the brain and the spinal cord. You've got two primary divisions of insult, as you see. Head trauma, so we're thinking about, both head injuries and TBIs, or traumatic brain injuries. Within that, head injury is basically a traumatic insult to the head that could result in injury to the soft tissues of the scalp or bony structures of the head and skull, but not including the face. TBI, so traumatic brain injury, impairment of brain function caused by an external force that may involve physical, intellectual, emotional, social, and vocational changes. So that's just changing everything up, isn't it? And then spinal cord injury, SCI, any injury of the spinal cord that disrupts normal spinal cord function. And we know that the head and spine, they're often injured in association with each other. So a lot of times with a head injury comes some spinal compression or some type of spinal injury as well, depending upon what the injury was. Now, a lot of this we're not going to go into because I'm not going to rehash your A and P with you. So we will hit on some high points, and that's about it. So some of the things to be thinking about is within the scalp, we know that it's a very vascular tissue and a very vascular region of the body. So we don't want to get distracted from things, as well as when you see, the scalp laying wide open and you're looking at the skull, you could become very distracted by that. You don't want to do that. We also don't, because it is so vascular, we don't want to underestimate the blood loss potential as well. So we're going to skip through a lot of this. So when you think about that, as you see right there with the brain, contains billions of neurons that serve a variety of vital functions. I mean, that tells us there's a lot of things going on within this thing, that all it takes is a small injury and a lot of things can change for our patient. So the cerebrum, responsible for the higher functions, we know that's divided into a couple of different hemispheres. Loss of blood flow for 5 to 10 seconds will result in unconsciousness in that area. So parietal lobe, perception of pain, temperature, and vibration. So obviously, hang on one second, let me see what I've skipped. So obviously with a injury to the parietal lobe, we're talking about right here, then someone would have a real issue with being able to perceive pain, temperature, vibration, all of those kind of things. So the frontal lobe, as you can imagine, here's the front, important voluntary motor action and personality traits. So it's going to be a big part of the way somebody is able to move, the way they're able to move their body and function basically every day. I believe it was that, let me look real quick. I believe it's the frontal lobe. No, I'm sorry. Let's move on. I was thinking of something else. Frontal lobe, parietal, occipital, processes visual information, temporal, controls speech. A lot of different things going on. Here's where I was thinking, the cerebellum. That's what I was trying to remember. The cerebellum is sometimes called the athlete's brain, and that's because it is responsible for maintenance, of posture, equilibrium, coordination, all of those things that it takes to be able to, compete or be an athlete or do something where you have to function at a little bit higher level than just, your normal everyday sitting around. So within the brain stem, it connects to the spinal cord and the rest of the brain. We should know already how important the brain stem is. Damage to the brain stem can produce some cardiovascular issues, some respiratory issues. It can even cause death. So we want to be very thoughtful whenever somebody has a brain stem injury. Meninges, talking about the spine, 33 vertebrae, 5 sections. see where we're gonna land at here. It's nothing new. Sympathetic nervous system controls sweating, pupil dilation. So we're talking about the fight or flight. Parasympathetic, rest and digest. So, scene size up. Getting to the scene size up. Hang on, let me catch up with us here. So, assess the scene safety, nothing new. Following should prompt a search for signs of head and brain injuries. So if our patient is a motor vehicle collision or crash patient, if they've taken a direct blow, if they fell from a height, if they were assaulted, those are all things, sports-related injury, had a head-to-head contact, those are all things that should make us start thinking that this patient could potentially have a head injury. Full spinal motion restriction, so high velocity crash with severe vehicle damage. The way these vehicles are being made now, they can take a lot bigger shot than they used to. So we really need to have a big, severe vehicle damage. Now, of course, this is all educational standards. Your protocol will certainly override these. Unrestrained occupant of the vehicle crash. So if the person was unrestrained. Vehicular damage with compartmental intrusion, and as I've said before, if you into the seating, when we're talking about this a seating space, if you get 12 inches of intrusion into the seating space, then that is a person that probably definitely needs to be seen. Fall of an adult from a height greater than 20 feet, fall of a child greater than 10, and then any penetrating trauma near the spine. This is we're continuing on, ejection from the moving vehicle, motorcycle crash of greater than 20, autoped, death of occupant, and then a rollover crash where the patient is unrestrained. So ensure manual stabilization of the cervical spine in a neutral inline position, nothing new. Determine the LOC, and as we start thinking about this, probably your brain, I know mine does, we automatically go to a bad call. We go to the big one. So we're just going to pretend like this was a bad patient. So we are going to stabilize, but on our assessment sheet we always talk about we're going to assess the need for it, but we're going to assume these guys need it. We're going to definitely determine their LOC. Oops. And then assess our ABCs, doing our primary survey, PMS, and then a cervical collar if findings require it. So if this is a bad crash, we know that this patient is probably going to need it. Airway and breathing, ensure an open airway. Be prepared to roll patients to the side to prevent aspiration. And then if a nasal airway is allowed, use caution. So CSF or bleeding out of the nose is present. We want to probably, it depends on, most times we're not going to stick in an airway. If nasal fracture is suspected, probably not as well. So maintain manual stabilization during all airway management procedures. Nasotracheal intubations carries a risk, and that is generally contraindicated in these patients with potential head injuries. So if the patient will not tolerate advanced airway, consider our DAI or our RSI, drug-assisted intubation or rapid sequence intubation. Moving on to ventilation, ensure adequate oxygenation and ventilation in any patient with a head injury. So, we don't want to withhold oxygen if they appear to have hypoxia. Regardless of what we might think, or maybe what we thought we heard, or whatever, because sometimes people get mixed up, and we're going to talk about this in a little bit, but about oxygenation and closed head injuries and hyperventilation and all these things. So if they're hypoxic, we do not want to withhold oxygen, because a hypoxic episode to these TBI type patients can cause some irreversible damage. So we want to make sure that that's not going to happen. So we're going to put 100% O2 on them with a non-rebreather mask. And then if they're not adequately ventilating themselves, then we're going to administer bag mask ventilation with 100% O2. We want to, if possible, with these patients, we want to keep them ventilated with their end tidal CO2. We want that to be somewhere between 35 and 40 we should use that kind of as a benchmark or a marker to keep our respiratory rate right around the correct area, which should be about 10 to 12 breaths a minute. We don't want to hyperventilate these patients just routinely, and we'll talk more about it when we do. There is a time where it is suggested that we hyperventilate these patients, but for the most part, we do not want to hyperventilate these patients just on a routine basis. So, hyperventilation is recommended only if signs of cerebral herniation are present. So here's what we're talking about. You see asymmetric or unequal pupils are bilaterally fixed and dilated. What's happening is all of that pressure is shifting over and causing that undue pressure on the pupils or on the nerve that controls it. Decerebrate posturing or no motor response to painful stimuli, and then a GCS of less than 9 that decreases by 2 or more points from the patient's best score. So basically they are deteriorating very fastly. And then I don't think it's, let me see if yeah. So, and then what we're going to talk about with the, what kind of hyperventilation pattern we want. So the Brain Trauma Foundation, what they recommend is adults, we're going to hyperventilate them at 20 breaths a minute, children at 25 breaths, and then an infant younger than 1 year old, we're going to hyperventilate them at 30 breaths a minute. It's pretty important that we keep it at those set rates. Circulation and volume resuscitation. So, obviously in the absence of a pulse, we want to immediately initiate CPR. We want to try to control bleeding with direct pressure the best that we can. If we do believe that there is a fracture, we can see it or we can palpate it, then we don't want to apply excessive pressure. As you can imagine, it's not good to push in bony fragments into the brain, so we don't want to do that. Examine the skin color, temp, and moisture. So, we're looking for a lot of different perfusion issues here. But patients with significant sensory loss, they can take on the surrounding environmental temperatures. So obviously when someone's laying on the highway, whether it's hot or cold, and if they're taking on those environmental temperatures, that could be good or it could be bad. And then remember, so with neurogenic shock, their skin's going to be warm, dry, and flushed. That's going to be one of the main differences with neurogenic shock versus, hypovolemic. Circulation and volume resuscitation. It might be necessary if the pulse is absent or diminished. So we want to get at least one 18-gauge IV. We don't want to administer dextrose-containing solutions because that can worsen cerebral edema. So it kind of goes back to that one thing where when we learned about D50, it's contraindicated in the head bleed, and it can increase cerebral edema, and then it can potentially leak out into the tissues and all of those things. We don't want to just routinely administer this, but if a patient is hypoglycemic, that's different. But this is just we're talking about as a fluid. So the only indication, remember, for administering glucose is confirmed hypoglycemia. That's the whole point of what we're saying. So one thing you want to think about is with these patients, it might be necessary that you need to volume resuscitate them. But if it is, we want to be thoughtful that we want to restrict our use of IV fluids for patients with severe closed head injury. So if hypotension develops, infused fluids needed to maintain a systolic of at least 90. We don't want to push a lot of fluids on them and create a lot of pressure in undue reasons. So patients in neurogenic shock, they may need vagolytic drugs, may need vasopressors. And then we want to use a monitor, obviously, for every critical patient. That's something you're probably already doing right now. So we covered our A, B's, and C's. We're going to move on to our D and our E. Disability exposure, reevaluate mental status and response, check for the presence of a pulse, evaluate motor and sensory function in each extremity, and then observe the back to assess for penetrating trauma. Don't get caught. Somebody got shot in the front and you missed. They got shot in the back also. So pay attention to this stuff. We want to make sure that we're doing a good job when we're looking at the back, so we want to palpate their back, feeling for deformities, step-off fractures, point tenderness, crepitus, all of those type of things that are going to help us determine whether the patient has an injury or not. Then we're going to, with all this, what's going to determine whether the patient needs spinal immobilization. Quick baseline assessment, obviously, we're going to need to do. We're going to oh man, I'm sorry. I'm boring myself, sorry. Remove any clothing that would obstruct your secondary assessment. So as we've said, and you'll continue to say it, and just because, I don't know, you always hear EMTs say, getting trauma naked, that's what we're going to do. We're going to make sure that we're going to respect their privacy and all of that. So, you know, we're not going to show off any goodies or anything, but we want to use trauma blankets to cover people up and keep them warm and all of that. But we do need to be able to determine whether there are other injuries that we need to work on. So when we suspect a head injury, one of the things obviously that we need to do is kind of get that baseline neurologic assessment. So one of the first things that we do is the old AVPU or AVPU. You guys should remember exactly what that means. So we're going to check if they're alert or if they respond to verbal, pain, unresponsive, whatever. Then we want to obtain a GCS. So as you can imagine, you may have a question about GCS coming up very soon. Because that's something that I've found, and I know when I went through school, I didn't do a good job of learning it. And I've seen it out in the field multiple times from every level, from a partner to a director, and now to an educator. I've seen that we don't do a great job of getting a very accurate GCS. So we're going to work on that and make sure that we can do that. So what you might even see is a couple of questions on a test about the GCS. And then if you don't get those right, for people that don't get those GCSs correct, there may be an additional assignment over how to determine a GCS. We'll see. So my suggestion is figure out how to calculate a good GCS. So when you suspect a head injury, obviously the level, the LOC or the level of consciousness, that is going to indicate the extent of brain dysfunction. The more brain damage and the more dysfunctional their brain is, obviously the less, the more severe alteration in mentation will be. So their LOC will be diminished, I'm trying to say. So a change in a level is the single most important sign that we can detect. LOC is always within everything, cardiac, neuro, trauma, everything. That needs to be our number one thing. So that's also nice whenever you've been chit-chatting a little bit and then all of a sudden something changes because you have this baseline of what you can expect from them, and now everything is different. So we want to format a plan. We've got to formulate a plan here. Go to the local trauma center probably. Consider air transport if we're going to be talking about, a pretty long time. And if we are going to be going by ground, we need to do so quickly, and we need to be cautious as well. Because many of these patients, as you can see right there, you know this already, but many of these patients are going to require neurosurgical interventions or surgery. So what we may be talking about, placement on a backboard, is a scoop stretcher. Similar device, talking about a KED, there's a lot of different stuff out there. Timing is based on the condition of your patient. So, sometimes you may have to do a rapid extrication where it might not be the best thing for the patient, especially if we're thinking or assuming that they have a traumatic brain injury. But it may be what's required by the patient. So, critical patient, apply the immobilization after the primary survey to enable rapid transport. Non-critical, apply the immobilization after the secondary assessment. So you're going, that we're really talking about is kind of that load and go, stay and play. This is what you're seeing here. Critical versus non-critical, and you see that we're talking about applying the mobilization after the primary, because after that, we're going to yank them out of there and get them into the truck. With non-critical, we're probably going to go ahead and do a little bit more thorough assessment, get them immobilized, get them extricated properly if we need to use a KED or we need to get more hands on them or whatever, because there's not time-sensitive injury or a time-sensitive matter that's on scene as well. Much like fires or or in the middle of the highway to where you can get ran over and all of those kind of things. So. Most patients can be log rolled while you watch for a deformity or injury. We need to be a good team leader here. Sometimes you may need to step back and get your hands off things if you've got enough hands and you can trust everybody to, so that way you can really pay attention to what you're looking at. A reliable patient meets the following conditions. So when they tell you, if they want to tell you all about their injuries and all of that, here's kind of some ideas about what that reliable patient looks like. So he's alert and oriented, no language barrier, no evidence of brain injury or intoxication by drugs or alcohol, and no alteration in his ability to make decisions or recognize pain and injury. Now, think back to all of your trauma patients. Most of them are going to have one or if not more of these things to discredit them. So, reliable patients following may eliminate the need for spinal immobilization. So a lot of this has changed nationally as well as within our state. And we have different protocols now regarding spinal immobilization. We found out that we were actually hurting people more than helping them by putting every single person that ever got bumped with in a 5-mile-an-hour car crash on a board with a collar and straps. So if they have no pain or tenderness along the spine, as well as, not just that, but as well as their normal neurologic exam, and then no distracting injuries. So they don't have any other type of injuries, then they're alert and oriented and not complaining of spinal pain, then you may not need to mobilize them. So always protect paralyzed limbs with appropriate restraint and stretcher immobilization. So if somebody, has a broken limb or they've sustained a head injury that is not made where they are unable to move things, make sure that you either use some tape to tape thumbs together or whatever you need to do, but make sure that everything's tucked in nice and tidy so it doesn't get caught on the bumper or whatever when you're moving them into the truck, because that's not good. So patients in severe pain may require an alternative method of transfer to a longboard. All this is just going to be dependent upon how many hands you have and what's going on. So sometimes, depending on the situation, you might be able to load them up a little bit on some pain meds prior to even moving them, which is a nice thing that they'll be thankful about. We want to say that time on the backboard should be limited. We're hoping that they will not be on a backboard all of that long because it can complicate a spinal cord injury. If you think about it, they've already got a spinal cord injury, and now we're going to throw them on their back and put all that pressure on that hard spine board, and you're probably going to get some kind of compensatory thing, some inflammation, all of that's going to cause potentially even more complications. So we want to be a little bit thoughtful of that. Several devices offer improved comfort: the vacuum mattress, back raft, concave backboards, so not just the straight flat ones. Here's what we're talking about. Towel rolls or blankets to pad voids. Nothing new. It's all stuff that we've all done and talked about and learned about and all of that. But it's pretty important to fill those voids all around if you're able to, because number one, it's a little bit more comfortable for them. Number two, it takes some of the pressure injuries off, as well as it makes it to where if you have to roll them while they're on the board, their body's not going to move and you're not going to cause more damage than they've already done to themselves. All right. So history taking. I think some of the things we need to think about, the patient's reliability should be assessed. We want to make sure, we saw earlier what we talked about, that how they would be reliable, basically if they weren't drunk, high, if they were alert and oriented, all of those things. Patients should be considered unreliable if they present with acute stress reaction, distracting injuries, alteration of mental status due to brain injury or intoxication. So some of the things we want to think about with these patients is they need to have continuous spinal protection until they've been cleared from the ER that you're taking them to. You also want to maintain a high index of suspicion for these guys. Treat all patients who experience major trauma above the clavicle or who are found unresponsive as if a spinal injury exists. So, there's several things that we've said, until proven otherwise, and this would be one of them. And then try to get a sample history if you're able to. Within the secondary assessment, depending upon what kind of call it is, and if you're able to get to a secondary assessment, we want to look at some of the things. So, circumstances of the incident, forces to which the patient was subjected, blunt penetrating trauma, all of these kind of things. Level LOC, their reliability, mechanism of injury. That's what I was kind of starting to list off a little bit. All of these things we want to start taking into account. So complete the physical exam. Oops, I'm sorry. Complete the physical exam with the patient in a neutral position without moving the spine, if possible. That's what definitely we want to do. Want to apply manual stabilization, administer RSI, depending upon the patient's ability to protect their own airway. And then we want to start looking for basically decap BTLS and all of that throughout the head and the neck. So soft tissue injuries, bony instabilities, any depressions, drainage, ecchymosis, so battle signs or raccoon eyes. Those should be really kind of letting us know that there is a real potential for some damage if you see either one of those, because one is probably a brainstem injury and another one is enough trauma to the face and maybe potential orbital fracture or something like that. Reevaluate these areas if the C-collar is not in place. So we want to frequently monitor the pupil size, shape, equality, reactivity, all of those things. Sluggish pupil is an early sign of increased ICP, but it also indicates cerebral hypoxia. So we want to make sure that if these patients are being treated with oxygen, if they are hypoxic, blown pupils, fixed and dilated, those type of things. Those are typically later signs, but they indicate pressure on one or both oculomotor nerves. And then evaluate the chest and abdomen for internal and external injuries. Cardiovascular system for signs of shock. We just went through shock. So male patients, look for abnormal posturing, obtain a glucose. So here you see, here's some stuff you're going to need to know for sure within your secondary assessment. So when you start looking at assessing intracranial pressure, mild elevation to moderate to marked, or you could look at that as severe. Increased blood pressure, decreased pulse rate. Pupil still reactive. So right there with that first point, when we see increased blood pressure, decreased pulse rate, if you throw in, you see Shane Stokes respiration or just some type of altered respiratory pattern, now we have something that we generally refer to as Cushing's triad, and that is a sign of increased ICP. So you see all these other things, altered LOC, all of these things, but we can kind of get an idea of what's going on with these patients by some of their signs and symptoms. Neurologic exam, intended to establish a baseline, which a lot of these things, when we're trending things, we want to establish that baseline and be able to compare one to the other, determine that LOC. We won't go much into this, but into the myotomes. But myotomes they're regions in the body where motor components of spinal nerves supply specific tissues and muscles, so where those nerves innervate and all of that. So you can see if you have a damage to one of those areas, then you can see that there will be dysfunction in those in the areas that are listed to the right, the muscle group area. Secondary assessment, we're talking about a neurological evaluation. Looking for equal strength, all of that. Dermatomes. And then reassessment. Vitals every 5 minutes in an unstable patient, 15 in a stable, nothing different. Be alert for hypotension without other signs of shock. Remember, if we believe somebody is in shock, we always say that it's hemorrhagic until proven otherwise. So, it's quick with these kind of patients to figure out that it's not hemorrhagic, but we start there and move on. Be alert for hypotension. And then check on our interventions. Repeat the physical exam, and then document suspected SCI or spinal cord injury. So, some of the things we want, the area involved, the sensation, dermatomes, I've not seen that documented that much, motor function, those kind of things. Moving on to the incidence of head trauma. So TBI, traumatic brain injury, is responsible for about 30% of trauma-related deaths each year. So that shows you how important it is to take care of these patients well and to do our jobs well and recognize these injuries. So some of the statistics that are listed in 2.8 million visits to the ED, 282,000 hospitalizations with 50,000 deaths, all directly related to traumatic brain injuries. So we want to be, pretty cognizant that this is a serious issue and that these people can certainly die if we don't do a good job of recognizing it. Types of head injuries: you got your closed head injury here. You also have open head injury. So closed, typically associated with blunt trauma. The dura mater is undamaged and the brain tissue is not exposed. Could result in skull fractures or TBIs, maybe focal or diffuse. Focal meaning limited to a focus area, or then diffuse is more spread out. So think about that when we start talking about pain and complaints and all of that. Make sure that you understand that diffuse is that more spread out. And then moving on to open, associated with penetrating mechanism of injury, penetration of dura mater, cranial contents, brain tissue open to the environment. That doesn't sound like it's going to be very good for somebody. So we want to make sure we're taking good care of these people. So scalp lacks, they can vary between minor and serious. You've probably seen both. They can certainly lead to significant blood loss. Scalp, consider the mechanism. Evaluate for signs of continued bleeding. Reevaluate. So stop the bleeding. Do not explore. Don't cram your fingers in there and try to figure out what's going on. Hang on a second. My notes got messed up. Here we go. So skull fracture, significance related to the type of the fracture. So whether it's something is a penetrating type fracture, or a linear skull fracture. If it's depressed or versus linear, or whatever, then even basilar, that's going to be bad, obviously. But a lot of different types of fractures, amount of the force applied, and then the area of the head that sustained the blow. And then potential complications, so intracranial hemorrhage, cerebral damage, cranial nerve damage. Those are all going to be complications. So when we say linear skull fractures, this probably accounts for the majority of all skull fractures right here. And you're not going to have any gross physical signs. Most occur in the temporal parietal region of the skull, so kind of where we're seeing right there. From getting knocked on, whether it's a window or fall down, go boom, those type of things. But not typically going to have something that is pointing you to believe that they have a skull fracture. Not like this, a depressed skull fracture. These result from high energy direct trauma. And then a lot of times they'll present with neurological signs, so we would expect them to be a little bit messed up. So, most of these, they result from high-energy direct trauma to a small surface of the head with a blunt object. So you can think of either certainly a bullet or a hammer, or, stick, whatever. Frontal parietal regions are most susceptible because the bones are relatively thin, and they have the greatest association with patient death. And then basilar skull fracture. So you can see over here, down here, we're talking about the base of the skull. Basilar skull fracture. So you start seeing raccoon eyes, you start seeing battle signs. So that atypical bruising, back here, and then raccoon eyes around here. So these usually occur following a diffuse impact to the head, associated with high energy trauma, but usually occur following diffuse impacts. Can be difficult to diagnose with radiography. So they include CSF, drainage, raccoon eyes, battle signs. And then the nasty one, open skull fracture, result of severe force, often associated with trauma to multiple body systems because there was just so much energy that typically it's all localized to that one area. It's not always true, obviously. But one of the things is you get exposure of brain tissue, and as you can imagine, these do have a high mortality rate. So this is where you don't go in poking, prodding, and trying to figure things out and all of that. Assessment and management. Use the pads of your fingers to apply pressure over the entire skull. Note any swelling or edema, deformity, depressions, all of that kind of stuff. Basilar skull fracture signs include, we mentioned it, CSF drainage from ears and or nose, raccoon eyes, and then battle signs. Now, one thing to think about is just because they don't have that doesn't mean they don't have a basilar skull fracture, because sometimes it can take up to 24 hours for these signs and symptoms to appear, or battle signs anyways. Identify and treat any life threats found in the primary survey as always. Provide manual inline stabilization. Provide supportive care for linear skull fractures, so lightly covered exposed brain tissue with sterile dressing. And for CSF leakage, apply loose sterile dressings, but do not stop the flow. Sometimes there's a reason for that, and we'll get into that's the body's way of doing things. Impaled objects should be stabilized and protected. There is times when that's not always true, not necessarily in the head, obviously, or not in the skull, but obviously in the head. So remember, when we start talking about airway issues, those are the only time that we ever do remove those kind of things. TBI is classified into primary and secondary brain injuries. Primary brain injury is injury to the brain and its associated structures. I don't think this, results instantaneously from impact to the head. And then secondary is, as you think about, like when we talked about explosions, you had that primary and secondary. Secondary is a lot of times just a secondary thing that causes issues with a secondary brain injury. The primary one is where they got struck. The secondary one is like cerebral edema, intracranial hemorrhage, increased ICP, cerebral ischemia. All of those type of things, hypotension, infection, a lot of different things can be that secondary brain injury. So it's a consequence, that's the word I was trying to think of, consequence of the primary injury. So it happened, secondary to the primary injury. So TBI, most common cause of an MVC. So we see the coup contra coup, which is here, that front and rear type injury, so that that brain gets rattled inside the patient's skull. It results in compression injury or bruising to the anterior portion of the brain, and stretching or tearing of the posterior. So the head falls back against the headrest or seat. The brain slams into the rear of the skull. So first, that passenger hits the windshield like we see here. Brain continues to move forward until it strikes the inside of the skull. Then the head falls back against their headrest or the seat. Brain slams into the rear of the skull. So you get that front and rear type of injury of the coup contra coup. Injured brain starts to swell because of those dilated vessels, and you immediately, as you can imagine, start to get an increase in cerebral fluid. So pressure essentially as well. Remember, these noggins are those sutures are all permanently done. There's no more no more pliability there. They aren't able to flex like with children to where they can grow. So you get a hematoma or something under there. All that pressure starts building up, and it's got to go somewhere. All right, let's get into the meat of this thing. I'll probably stutter and stammer quite a bit, so just be patient with me. Intracranial pressure. An increase in ICP, or intracranial pressure, can be caused by accumulation of the blood within the skull, so we just talked about that, as well as swelling of the brain. And remember, it has to go somewhere. Something has to, it doesn't have to necessarily go somewhere, but something has to give, I guess is what I'm trying to say. So an increase in the ICP decreases cerebral perfusion pressure and the blood flow. So the bad thing about that is when you start thinking about it, is you are not able to perfuse the brain the same way that that you once were able to. Now, we're not going to go into this equation. You should remember the MAP. The cerebral perfusion pressure is the difference between the MAP and the ICP. Typically, normal ICP is going to be between about 5 to 15. We're not going to know that out in the field. Maybe if you work on some specialty care transport and you've got some high-tech equipment, you would be able to monitor that, but you're probably not going to be able to figure that out on your own. Not that I'm aware of. Doesn't mean that there's not. But so remember, talking about this, an increase in ICP, it can be caused by an accumulation of blood or the swelling of the brain. So the increased ICP squeezes the brain against the bony prominences within the cranium, which obviously is not good. So when we talked about the CSF with the body, kind of trying to fix itself, and it's not fixing itself by doing this, but it's trying to get rid of things to make room for stuff. It starts throwing out the CSF and venous blood from the cranial vault. So once it does that, then the ICP begins to rise, as you can imagine, because of all of the venous bleeding, the bleeding, and everything else that's going on in there, and then the swelling, and the ICP begins to rise. The cerebral perfusion pressure now, it begins to drop, and then the body attempts to maintain that by increasing the MAP. So, probably not making a lot of sense right here, but just start trying to think about this whole thing. When we think about Cushing's triad, one of the things that we see is a high blood pressure, right? We also see a widening pulse pressure. So let's go back for a second. The body reduces the ICP by expelling the CSF, right? Then the ICP begins to rise, intracranial pressure begins to rise, cerebral perfusion pressure begins to drop, and the body attempts to maintain cerebral perfusion pressure by increasing the MAP. So that's when we start to see that rise in blood pressure. There are a few other things that affect interfere cerebral perfusion pressure. Excess carbon dioxide in the blood, hypotension, swelling, bleeding, all of those kind of things. They also will interfere with that pressure. So really, the treatment should focus on maintaining the cerebral perfusion pressure, so essentially cerebral blood flow, while mitigating or kind of combating ICP. Hang on, I got to get a drink after all that, or a drink of water. Okay, here we go, picking up where we left off. Just got me a big old drink of water, so I'm ready to go again. I think I was getting dehydrated from all that talking. Herniation. One of the things we would like to be able to prevent in this type of situation, but it's one of those things that goes on. So brain is forced from the cranial vault through either foramen magnum or the tentorium. So if you need to, make sure you open up your book and figure out where those two structures are, and you can understand why that's a really bad thing, because it starts to herniate, starts causing undue pressure, causes a whole lot of problems. Lateral herniation syndrome, or the uncle herniation syndrome, that is the most common form of herniation. So basically, a portion of the temporal lobe, or the uncus, is displaced laterally. Pretty fancy name, lateral herniation syndrome, and it's displaced laterally and it's herniated. So as you can see, they make it a little easy for us paramedics. Moves downward through the tentorium incisura, not sure what that is, but compresses the midbrain and posterior cerebral artery. So some of the things that we look for as signs of herniation, they start to include the ipsilateral pupil dilation. So you start to think about you'll have pupil dilation on the same side as the head injury, contralateral motor dysfunction, and then we move on down. A central herniation syndrome occurs when the brain tissue shifts downward and ultimately compressing the brain stem from above. And when that starts happening, it ends up that the brain stem compression, it starts to destroy the respiratory center, induces apnea, decreases perfusion to the rest of the brain, and ultimately, as you can imagine, it causes death. So that is a really bad thing. So when we start talking about ICP, because that's what we're doing, we're talking about intracranial pressure, and all of that pressure causes the brain to herniate, causes that shift. So some of the things: vomiting, headache, altered LOC, seizures. Then you move on to the later signs, the ominous signs, the really bad ones: hypertension, widening pulse pressure, bradycardia, Cushing's triad, non-reactive pupils, coma, posturing, all of that. So within that, the thing with Cushing's triad, you start to see some changing in respirations also. Triad being three parts: hypertension, bradycardia, and then an altered respiratory pattern. Typically, you're going to see Shane Stokes or even central neurogenic respiration. So that's more than likely what you're going to see. But if you'll just remember an altered respiratory pattern, that will help you out remembering what Cushing's triad is. Now, within posturing, you guys should already remember this, but decorticate, we're talking about flexion of the arms and extension of the legs. And then decerebrate, which is worse, extension of the arms and legs. And I just remembered that decerebrate has a lot of ease, like extension does, and everything's being extended out. So within those signs of posturing, that is going to be the bad one. So these ones right here, this is really bad. That's what we're hoping to not see. Diffuse brain injuries. So cerebral concussion, basically it affects the entire brain. You know, that brain just gets jarred around within the skull. It's caused by rapid acceleration and deceleration forces. And what it does is basically forces the damaged cell membranes of the neurons, which depresses the neuronal activity. And that starts to result in transient dysfunction of the cortex. So signs start to, some of the stuff that you start to see: headache, confusion, disorientation, loss of consciousness, retrograde amnesia, or anterograde amnesia, post-traumatic. So before and after amnesia, basically. Moving on, cerebral concussion assessment and management. Complete the primary survey. Hang on, let me make sure I didn't miss anything here. Nope. So, assessment and management: perform a primary survey, address any life threats. Secondary assessments directed at evaluating for the presence of a concussion. So if you suspect a concussion, you should probably do a thorough evaluation. So assessment will focus primarily on cognition. Patient history is the key component. So ask them to assess his or her memory and awareness of, so basically we're going to check their A&O, right? We're going to check the awareness of person, place, time, and situation. So some of the things that you might see with a concussion: headache, fatigue, confusion, inability to recognize people or places, disorientation, dizziness, difficulty concentrating, memory deficits. A lot of different things. So pay attention to those in your book. You'll want to know what those are. Moving on, second impact syndrome. So ask the patient about recent concussions. It's something that's important because second impact syndrome is a rare but often fatal result of receiving a second concussion while still recovering from an earlier concussion. Something we see in football quite a bit because people aren't coming off and sitting on the sidelines long enough. So the brain becomes very vulnerable and it's disrupted during recovery. So what happens, the minimal force can be exerted upon the brain at the time, and increases the blood flow, brain herniation, and ultimately death. So it can occur in 2 to 5 minutes after the injury. So you start to have a sudden LOC after suffering a blow to the head, stunned appearance, loss of eye movements, dilated pupils, coma, respiratory failure, cardiac arrest. So our biggest thing that we're going to do is just support them. We're going to give general supportive care. Post-concussion syndrome: at least 3 of the following signs for 3 months following a concussion. So headache, dizziness, insomnia, memory difficulty, all of those things. Now, a lot of this stuff has not changed because head injuries are head injuries. So since you took your EMT class, there's not been much changing. So this is one of the most common ones. So we're going to kind of go through this kind of quick because I'm feeling a bit suicidal up to this point. So diffuse axonal injury, one of the most common diffuse brain injuries. It also has a high mortality rate. What the problem with it involves stretching, shearing, tearing of nerve fibers, and axonal damage. It's caused by high-speed, rapid acceleration or deceleration forces, and classified as mild, moderate, or severe. Once again, with this, it's going to be supportive. Supportive care is what we're going to do, and we need to get to a neurology, ER with a neurology department. Cerebral contusion, brain tissue is bruised and damaged. Well, just think about the word contusion, bruised and damaged. So greater neurologic deficits are observed with cerebral contusion than with a concussion. And swelling of the brain, because that's what we're talking about, right? It's bruised, so you're going to get that swelling. It can lead to increased ICP as well. All right, let's talk about some different kinds of hemorrhage, intracranial hemorrhage. Epidural, so we see that's an accumulation of blood between the skull and the dura mater, results from a blow to the head. So that happens in about 0.5 to 1% of all head injuries, always results from a blow to the head. Typically you see a immediate loss of consciousness and then a brief lucid interval and then another loss of consciousness. So someone passes out, they come back and they're with it, and then they pass out again. It typically has a high survivability with early treatment, surgery. So some of the signs and symptoms as ICP increases, so ipsilateral pupil dilation, nausea, vomiting, seizures, urinary incontinence, visual disturbances. Moving on to subdural, accumulation of blood beneath the dura mater and outside the brain, so you can see right over here what we're talking about. Most common intracranial hemorrhage, it's associated with venous bleeding, so ICP develops more gradually. And they have a fluctuating LOC or level of consciousness, focal neurologic signs, or slurred speech. So you see acute, subacute, or chronic. That's classifications for these. Headache, dysphagia, hemiparesis, personality changes, visual disturbances. Then intracerebral hematoma. So that refers to bleeding within the brain tissue itself. Once again, we're talking about right here. Results from penetrating injury to the head. Many are associated with other brain injuries, such as diffuse axonal injury, and the patient's condition deteriorates quite quickly, as you can imagine, with it being right inside the brain. So, high mortality, even with surgery. Move on to a subarachnoid. I don't think, does this not have, no. Sure why there's not a picture, but bleeding to the subarachnoid space results in bloody CSF and meningeal irritation. Causes include trauma or rupture of aneurysm. Patient typically presents with a sudden severe headache. So, this might be that really bad headache that we've heard about. Subgaleal hemorrhage, bleeding between the periosteum and the galea, can result in enough blood loss to precipitate hypovolemia in infants. And then a supragaleal hemorrhage, so firm nodular mass. So you might think about kind of the goose egg. The goose egg thing is what we're talking about. Thermal management, do not allow the patient to develop hyperpyrexia, so we don't want them to get hot, because sometimes that can happen within the patient with a head injury. Hang on a second here. No. I've lost my spot. Oh, there we go. Okay. All right. So we didn't have... Let's talk about that for a second. So general management of head trauma. Treatment priorities must be based on the conditions that will kill the patient first. So, obviously if they have airway issues or bleeding issues or whatever, we want to take those. We also want to check the breathing rate, pattern and rate. So by looking at some of these things, we are starting to watch closely for signs of increasing ICP, because we start looking at the breathing rate, we start looking at some vital signs, all of those things. We want to make sure that we're not on scene longer than 10 minutes. Get an open airway. Do not allow for hypoxia or even hypercapnia. We don't want either of these. So en route, get you an IV. Look for your blood glucose. Don't get tricked. I've already seen it on a few scenarios so far, that it was a simple blood sugar issue, and a couple of guys got tricked thinking it was a stroke. So let's make sure when we start talking about our altered mental status stuff that we are taking care of the simple things first, kind of that KISS, keep it simple, stupid thing. So We want to start looking for blood sugars and all of those things. Seizures as well. If someone has a seizure, sure, it could be from a head injury, could be because they're hypoglycemic, could be of drug overdose, could be a lot of different things. So within these patients, we also want to consider chemical restraints, possible sedation. The hyperpyrexia, that can worsen the condition of the brain, so we don't want to cover these patients up with blankets. We're not going to be using probably any meds, but it is good to know these two are diuretics. So osmotrol or mannitol used to be used, and from what I never used it, but from what I understand, people that would use it and it had increased intracranial pressure and cerebral edema and all that, it would pull that fluid off and people would get better. But I don't know if they had a flashback or what, but from what I understand, people would get better and then all of a sudden pretty much die. So we're not using that. And then Lasix, I've not ever seen it used in these situations in the field, but it is a osmotic diuretic, so it's going to allow the body to pull some fluid off. Benzos, however, we will be using those to control those seizures, because a lot of strokes or head injuries can certainly have a seizure. So we'll probably be using some benzos. Spinal cord injury. Limited treatment options, obviously. So reducing incidence is the best option. We don't. That's not where we are. We don't have that luxury of probably reducing the incidence of that. Somewhere there's some. I mean, in the United States, somewhere there's about 17,000 new cases each year of this spinal cord injury. Mortality rates are the highest in the first year after the injury, and sometimes people will die from. Or not sometimes. The leading causes of death for these guys are pneumonia, pulmonary embolism, or sepsis. Flexion injury. Moving on. So result from forward head movement of the head. Forward movement, I'm sorry, not head movement of the head. That's result from forward movement of the head. Typically results of rapid deceleration or a direct blow to the occiput. So the problem with that, at C1 or C2, as you can imagine, that's a bad place to have an issue, but they can produce an unstable dislocation with or without a fracture. So from what I've been told, you can get a dislocation up there, and that's a little bit disturbing. If you've ever seen an owl kind of do things, that's my understanding. It kind of looks a little bit like that. So we want to be pay attention to that and probably do a good job of immobilizing that. Injuries are considered unstable with that rotation with flexion. Vertical compression, not an uncommon injury from someone that falls from a height or is either falling maybe out of a tree or those type of things. But you can results from a direct blow to the crown or rapid deceleration from a fall. So taking a headshot on the way down or landing hard, and all energy transfers up through your feet and your legs and into your pelvis. Then essentially what happens is that energy is then all transmitted into your vertebrae, and you see that vertical compression. One of the worst parts about this is you can actually cause a compression fracture, even herniation of the disc, or some fragmentation, and then that becomes embedded in the cord, which can become a real problem. Distraction, opposite of compression forces. A distraction injury results when parts of the body are pulled in opposite directions. So most classic distraction injury would be a hangman's fracture, which is what we're seeing here. Lateral forces cause bending and fractures at the C1, C2, which quickly tears apart the spinal cord. And hyperextension, not much to talk about here, results in fractures and ligament tears, ligament damage. So the primary SCI, as we've talked about, primary and secondary and all those things. Primary occurs at the moment of impact. Penetrating trauma results in transection of the neural elements and complete injuries. Blunt trauma, however, results in compression of portions of the spinal cord for an incomplete dislocation. Spinal cord contusions. Those guys are caused by fracture, dislocation, direct trauma. Cord laceration caused by a projectile. And then that secondary, so that occurs when multiple factors create a progression. Progression of the primary spinal cord injury. So minimize further injury through stabilization, neutral alignment, and spinal immobilization. We definitely want to minimize their heat loss, work on perfusion, oxygenation, all of those things. Anterior cord syndrome. So displacement of the bony fragments into the anterior portion of the spinal cord. You start to see paralysis below the level of the insult. Also can have a loss of sensation to pain and temperature as well. And then the central cord syndrome. Hyperextension injuries to the cervical area present with hemorrhage or edema. Posterior cord associated with extension injuries, relatively rare. Cauda equina, compression of the bundle of the nerve roots, so can produce the following: low back pain, paresthesia, myasthenia, loss of sensation. Brown-Séquard syndrome typically occurs after penetrating trauma. You can have some non-traumatic causes though, disc herniation, spinal cord tumors, those kind of things. And then spinal shock, temporary local neurologic condition that occurs immediately after spinal trauma. So typically you get some swelling and edema, usually within about 30 minutes. Neurogenic shock results from the temporary loss of autonomic function at the level of injury. Hemodynamic and systemic effects. So you start thinking about shock. So hypotension, decreased stroke volume, all of those things. And remember, with neurogenic shock, we might see some bradycardia. So hypothermia, you these guys start losing a lot of functions. So the evolution of spinal care. Immobilization is one of the most common emergency medical service or EMS procedures. Preventative immobilization of all trauma patients became routine. So we just used to backboard everybody. So there's still one of the things that we do now though is we evaluate each patient. So we have these kind of a little more stringent, I shouldn't use the word stringent, but specific indications for immobilization. And as you can see here, the debate still goes on. I've been told, or I heard in a presentation, they're talking about maybe doing something different with collars as well, but that was probably a couple of years ago. But I know in Las Vegas, where this doc was from, they were doing something different with collars. So all kinds of stuff are changing. These are all some negative effects. Pain in the occipital sacral lumbar area, neurologic deficit, ulcers, increased risk of aspiration, respiratory compromise, increased ICP, difficult airway management. Here we go. Views on immobilization may be based on historical approaches. Always follow your local protocols. And then three common approaches to immobilization. So all trauma patients are immobilized based on mechanism. Patients with an identified mechanism are evaluated for the presence of spinal injury. And then patients with a mechanism are evaluated for presence of spinal injury based on selective criteria and either fully immobilized, placed in a collar only, and secured to the stretcher without a backboard or not mobilized. So you have a lot of different things going on. We're talking about assessment and management of these guys. Nothing different. Primary survey, A, B, C, D, and E. Treatment plan. Perform those treatments. During the disability phase, it's going to be a little bit different. So, you're going to want to do a complete assessment for a spinal cord injury. So, looking for deformities, crepitus, step-offs, point tenderness. You want to do your neurological exam. So, your AVPU and your GCS. Place a collar if indicated, and then follow your protocols. Spend no more than 10 minutes on scene if you believe this is a spinal cord injury patient. Use a slower approach, obviously the load and go. Don't ignore life threats to airway, breathing, circulation by messing around with immobilization and packaging. It sucked to have a messed up airway, but they were packaged perfectly and you forgot about the airway, neglected that. So let's not do that. Consider the spine one long bone. Traditional spinal mobilization uses a C-collar, cervical immobilization device, long spine board. I'm not going to go into this. You guys are all good at this stuff. KEDs. Pharmacotherapy for treatments of spinal cord injury. Let me get to that. My gosh. Here we go. All right. So, short-acting reversible sedatives are commonly recommended for acute agitation because we want to calm people down. One thing that we know for sure is if we have somebody that's already injured and then they're agitated or a little bit delusional or whatever, we can certainly create more harm than good. So we may need to give them a sedative. Pain medication may be necessary. A lot of these are nice if you have something like ketamine, some kind of dissociative medicine, and that allows them to just kind of go away. And there used to be a lot of corticosteroids that were used in the field. A lot of that has went away. They found out it doesn't do as much as they thought. But as you can imagine, with SCI, we can have the potential for aspiration, respiratory arrest. It all depends upon where the injury is and how severe it is. But predisposal to atelectasis and pneumonia. So if people are unable to take big, deep breaths. Now, this is not going to happen on scene, obviously, atelectasis and pneumonia. But deep vein thrombosis, pulmonary embolism, those are all late things as well. Autonomic dysreflexia, so that's potentially life-threatening. Most commonly occurs with injuries above T4 to T6, and we're talking about is just a big old uncompensated cardiovascular response. So you get a big old dump of adrenaline, systolics going greater than 200, diastolic greater than 130. So as you can imagine, that's not going to be good because it has some cardiac complications. I think I went the wrong way, didn't I? Back pain, we're not going to talk much about that. Occupations, we're all running back pain calls. Consider disease processes that can result in debilitating lessons. Now, it's really easy to throw everybody into that, lump everybody into that pile of people complaining about back pain if they're med seekers and all that. But there are many people that have had some type of work-related accident or car crash or whatever that has left them with a back injury. So it's probably not fair for us all to assume that they're just drug seekers. So don't look at everybody that way. Pay attention to the medications. Degenerative disc disease, disc loses the height and shock absorbing effect. Stenosis, the narrowing of the spinal canal. Injury prevention. That is it, my friends. 1 hour and 9 minutes later, and that was head and spine trauma. So, all of the most important things out of this is going to be what goes on within the brain whenever that injury happens. So the increased ICP, how to recognize that, the body's reactions to it, Cushing's triad, the different bleeds, obviously the management, that type of stuff. That's going to be your most important things to pay attention to. So this is Curtis signing out, and we'll see you soon.